So REO views and LEO views have different pros and cons. REO gives you an idea of how far forward or anterior your catheter is and how far posterior your catheter is, so you can monitor your ablation from the anterior portion of the septal leaflet of the tricuspid valve and drag back and watch it come more posteriorly as you go. It also gives you information of how superior or inferior your ablation catheter is relative to a reference point, such as a His catheter, for example, but it doesn't give you information on how medial or lateral you are. And so if you're drifting medially towards the coronary sinus ostium, you won't really get a good handle of that by looking at an REO view. But you can look at things such as your electrical data. Are you getting CS ectopics? Is your ablation signals on your ablation catheter starting to look like your CS signals? Is your impedance going up? So there's other information to look at. LEO views gives you information on how medial or lateral your catheter is. It gives information on how high or low your catheter is, but it doesn't really give information on how anterior or posterior you are. And so if you start ablating at the level of the tricuspid valve and start pulling back, you don't really get a sense of how far you're in fact pulling back. And so are you too far posterior in the coronary sinus ostium? Are you too far forward towards the tricuspid annulus? Of course, you could look at your signals. If you've got all ventricular signals and no atrial signals, your catheter is probably too far anterior towards the tricuspid annulus. And if your impedance is rising, you might be falling into the coronary sinus ostium. So there are other things to look at apart from your fluoroscopic views. We've gone over the anatomy of the triangle of Koch before, but it's important to reiterate the point in the context of ablation of slow pathways. Here we can see a beautiful illustration of the triangle of Koch, and this is from a paper actually looking at His bundle pacing, but we've appropriated it for our purposes because it beautifully illustrates the area. We can see the tendon of Todaro in this sort of region here, forming one side of the triangle. We can see the septal leaflet of the tricuspid valve forming the other side of the triangle, and we can see the base of the coronary sinus ostium forming the base of the triangle, and then they've marked out the compact AV node in red. So we'd expect a His catheter to be sort of located in this sort of region. I'll do that in purple, in this kind of region here. And so we'd expect the coronary sinus catheter to be located inside the coronary sinus. And so we'd expect the fast pathway to be anteroseptally located in about 90-85% of patients. And so we'd expect fast pathway location to be anteroseptal relative to the tendon of Todaro. And we'd expect the slow pathway to be posteroseptal, where it's posterior to the septal leaflet of the tricuspid valve, but anterior to the coronary sinus ostium. So it seems simple then to place an ablation catheter anterior to the coronary sinus ostium, but posterior to the septal leaflet of the tricuspid valve, where you have a 1:3 or 1:5 A to V amplitude ratio, perhaps with some fractionated electrograms representing disrupted fiber orientation and disrupted conduction through this region. Start radiofrequency ablation and drag the ablation catheter sort of towards the coronary sinus ostium, and hopefully we take out the slow pathway. But it's important to recognize that significant variability exists in the position of the fast pathway and compact AV node. So what this paper is actually showing is an inferiorly displaced compact AV node towards the coronary sinus ostium. And you can imagine that if your ablation catheter is slightly higher than the coronary sinus ostium here, you could inadvertently injure the compact AV node and affect the patient's AV nodal function. In some patients, the compact AV node and therefore the His catheter may be located in the usual position, but their fast pathway could be inferiorly displaced, perhaps in the mid-septal region, kind of in this location, or perhaps in a posteroseptal region in a very small minority of patients in sort of this location. And in these patients, you can imagine that inadvertent injury to the fast pathway is quite possible in the context of a slow pathway ablation. And with fluoroscopic guidance or even 3D electroanatomical mapping guidance, you may not immediately recognize that this fast pathway is inferiorly displaced. And the point of this is that we have to be vigilantly observing our EGMs and our ECG during slow pathway ablation in order to watch for any evidence or signs of inadvertent injury to the AV node of fast pathway and any evidence of PR prolongation or AH prolongation, warrants immediate cessation of ablation, but we'll discuss this in more detail soon. So at this point, we're able to identify the approximate slow pathway region to target for ablation. But once radiofrequency energy is applied, what sort of signals should we be looking out for during the ablation? What signals indicate the need to immediately stop ablating, and what signals might represent a positive predictor for ablation success?